Sepsis is an exaggerated immune response to infection associated with organ dysfunction, shock, and death. The infection can be bacterial, viral, or fungal and may originate from any tissue, initiating a complex interplay between infectious virulence factors and host defense mechanisms. The main goals of management are to identify and treat the infection while maintaining hemodynamic stability to prevent or minimize organ damage. Once you identify sepsis or septic shock, you should provide immediate supportive care and begin searching for the underlying source of infection. When you encounter a patient presenting with signs and symptoms of sepsis, first perform an assessment with a validated metric, such as the Systemic Inflammatory Response Syndrome, or SIRS criteria. There are numerous causes of SIRS like sepsis, dehydration, and adrenal insufficiency, so sepsis will cause SIRS, but SIRS is not always due to sepsis. To diagnose SIRS, at least 2 criteria must be met. These include WBCs either below 4,000, so leukopenia, or above 12,000, so leukocytosis, as well as a body temperature either below 36 degrees Celsius, so hypothermia, or over 38 degrees Celsius, so fever. Heart rate above 90 beats per minute, so tachycardia, and respiratory rate over 20 breaths per minute, so tachypnea. Now, if the SIRS criteria are not met, you should consider an alternative diagnosis. On the other hand, the presence of known or suspected infection together with SIRS should raise suspicion for sepsis. In addition, if systolic blood pressure, or SBP, is below 90 millimeters of mercury or falls 40 millimeters of mercury below baseline, your patient has septic shock. While the SIRS criteria help you identify patients with sepsis, other metrics, such as the Sequential Organ Failure Assessment, or SOFA score, may help identify those at greatest risk of poor outcomes. SOFA evaluates parameters including mental status, mean arterial pressure, or MAP, respiratory function, creatinine, bilirubin levels, and platelet count. The higher the score, the worse your patient's prognosis. Now that sepsis or septic shock has been identified, there are several tasks, known as the 1-hour sepsis bundle, that you'll need to complete. These measures are to ensure that the underlying infection and hemodynamic status are addressed quickly, as failure to do so can result in disastrous outcomes for your patient. First, measure blood lactate levels STAT, which will be used soon to help guide hemodynamic management. Second, collect blood cultures, after which you will begin broad-spectrum IV antibiotics. Finally, focus on the SBP and the lactate level results. If the SBP is above 90 millimeters of mercury and the lactate level is normal, your patient has sepsis without shock. On the other hand, if your patient's presenting or subsequent SBP is below 90 millimeters of mercury or has fallen 40 millimeters of mercury below baseline, or if the lactate level is above reference range, your patient has septic shock. The presence of an elevated lactate level is an indirect indicator of organ dysfunction, as lactate is produced in the setting of hypoperfusion. All right, let's take a look at sepsis without shock. These patients can be continued on maintenance IV fluids. The rate of IV fluid infusion should be adequate to maintain a urine output of 0.5 milliliters per kilogram per hour or more, and a capillary refill time, CRT, of less than 3 seconds, as these are reliable indicators of tissue perfusion that can be observed at the bedside in a stable patient. On the flip side, there's patients with septic shock. These patients are inherently unstable and will require hemodynamic resuscitation. Once septic shock is recognized, immediately begin an IV infusion of IV crystalloids dosed at 30 milliliters per kilogram. Consider admission to the ICU and placement of catheters for invasive hemodynamic monitoring, including an arterial line and a central venous catheter, or CVC. During the infusion, MAP should be monitored with a target of 65 millimeters of mercury or above. MAP can be calculated from manual blood pressure readings, but these are much less accurate in the setting of hypotension than those measured by an arterial line. If the MAP falls below 65 millimeters of mercury, IV vasopressors, such as norepinephrine or dopamine, should be added. Vasopressors are best administered through CVC, but if one has not been placed, they can also be given through a peripheral IV. However, there is a small risk of peripheral tissue necrosis associated with peripheral infusion of vasopressors, especially if given for long periods of time. If the MAP remains below target, additional vasopressors, corticosteroids, and even RBC transfusion may be added to reach a MAP of 65 or more. Once a MAP of 65 millimeters of mercury is achieved, the rate of crystalloid infusion and doses of vasopressors should be continued and subsequently titrated to maintain this goal. Now, whether your patient has sepsis with or without shock, establishing hemodynamic maintenance completes the 1-hour bundle. But you're far from done. You'll need to closely monitor indicators of perfusion and hemodynamic parameters, as even stable patients with sepsis or septic shock can decompensate quickly. Failure to maintain adequate perfusion will inevitably lead to hypoperfusion of vital organs and organ system failure. Okay, now that the 1-hour sepsis bundle is complete, you'll need to turn your attention to a thorough history and physical examination, as well as order labs and imaging. Your goal is to identify the source of infection and any organ dysfunction as soon as possible so that proper investigations and interventions can be undertaken. When gathering your patient's history, ask questions or explore the chart for clues to the source of infection. If the patient is already hospitalized, let's say for pneumonia, then that's your most likely source, underlying pneumonia. It won't always be that obvious, though, so taking a thorough history that covers all organ systems and common infectious manifestations is important. Similarly, your physical examination should be comprehensive, looking for abnormalities that might point toward underlying infection or organ system dysfunction. The presence of suprapubic tenderness, for example, might suggest a genitourinary infection, while findings of bruising and petechiae may indicate disseminated intravascular coagulation, or DIC, as a manifestation of circulatory failure. Now let's look at labs. Get a CBC with differential and look for elevated WBC count with a left shift. Order electrolytes, liver function test, BUN and creatinine, and an ABG to help you identify organ dysfunction. Coagulation studies and a D-dimer help evaluate for DIC. In the event the infection is difficult to localize, an elevated procalcitonin supports your suspicion of a bacterial infection and helps direct antibiotic management decisions. Lactate levels can be used to guide the intensity of hemodynamic resuscitation measures. Next, let's look at microbiology. You've already sent blood samples for culture, so now you should send other suspected infectious source samples for culture, such as a sputum sample if pneumonia is suspected, or a CSF sample if there are signs of meningitis. Finally, you'll want to order imaging studies to evaluate potential sources of infection based on findings from the history and physical, like a chest X-ray to evaluate for pneumonia or to identify complications that guide clinical decisions, like a head CT to rule out increased intracranial pressure and suspected meningitis prior to performing lumbar puncture to obtain CSF. Clues from your history and physical or imaging results have helped you narrow down suspected sources of infection, while cultures have hopefully identified the causative organism. Now let's reassess your patient's antibiotic coverage. A confirmed infectious source will help you choose the most appropriate antibiotics and how long you will give them, as well as which ones can be discontinued. Tailored antibiotics are continued for a duration specific to the underlying infection, like after 3 days for uncomplicated UTI or 7 days for a hospital-acquired pneumonia. On the other hand, if the source and cause of infection remain a mystery, you will continue the broad-spectrum antibiotics started early on. In this event, decisions about the intensity and timing of antibiotics can be made by following procalcitonin levels. A procalcitonin level that falls from baseline indicates a resolving infection. Even after being started on antibiotics, a patient with sepsis can still decompensate quickly. Be sure and check hemodynamic parameters frequently and intervene rapidly if developing shock is recognized. If your patient remains hemodynamically stable, their current fluid or vasopressor regimen should be continued. Don't forget that sepsis is associated with organ dysfunction. This is closely related to hemodynamic maintenance, as failure is inevitable when an organ is underperfused, as well as to direct tissue damage caused by circulating pro-inflammatory cytokines and bacterial endotoxins. New exam findings may emerge, such as a drop in oxygen saturation or development of edema, that might indicate that one or more organ systems is failing. In addition, as your patient's lab results return, you may find abnormalities that suggest organ dysfunction. Significantly elevated AST and ALT, sometimes into the range of 10,000 units per liter, as well as elevated bilirubin levels, may indicate acute liver failure. Similarly, a significant acute elevation in the serum creatinine or decrease in urine output should raise your suspicion for acute kidney injury. Prolonged PT and PTT, especially if there's an acute drop in platelet count, may suggest the presence of disseminated intravascular coagulation, or DIC for short. Finally, some manifestations of organ dysfunction manifest on imaging, like the development of pulmonary edema on chest X-ray. If there are lab and imaging abnormalities suggestive of organ dysfunction, you should consider consulting with a specialist. It's not uncommon for multiple specialties, such as pulmonology, nephrology, and infectious disease, to be involved in the management of a patient with sepsis or septic shock. All right, as a quick recap, sepsis is a life-threatening condition that occurs when an overwhelming systemic response to infection results in organ dysfunction, shock, or even death. The diagnosis of sepsis is clinical, but aided by validated screening tools like the SIRS criteria, which takes into account the patient's WBC count, body temperature, heart rate, and respiratory rate. Early stabilization of hemodynamic status, identification of infection, and initiation of antibiotics are the keys to successful management. Even when these measures are undertaken, your patient must be monitored very closely to avoid decompensation and increase the likelihood of good outcomes.
Everyone who's ever had a pimple has had an abscess. Even though they're tiny, they're still abscesses. Now, an abscess forms when normal tissue, like skin for example, is split apart and that new space is invaded by nearby pathogens like bacteria. And there are roughly 10 bacterial cells for every 1 human cell, and they cover every surface of the human body. So any cut or break in the skin or closed off area within the body is an invitation for bacteria to dive in and multiply. When that happens, the immune system typically responds, and a battle ensues with the result being pus, a mixture of bacteria, immune cells, and dead tissue. So, in response to an injury, the tissue releases small chemicals in the local area called cytokines, like tumor necrosis factor, interleukin 1, interleukin 6, interleukin 17, and chemokines, which attract nearby white blood cells, which are part of the immune system. It's kind of like yelling for help and being heard by the nearby police. In addition to attracting immune cells, the cytokines also dilate nearby capillaries, which brings more blood to the site, and make the capillaries more leaky, so that the white blood cells that do show up can slip out of the blood and get into the tissue more easily. Oftentimes, the first immune cells at the scene are neutrophils, which release chemicals and enzymes that kill bacteria and dissolve pieces of dead cells, creating a pool of dead material. This is a specific type of acute inflammatory response called suppurative inflammation, which simply means that pus is created in the process. From a macroscopic view, this is sometimes referred to as liquefactive necrosis, because the area of dead tissue turns into liquid. As those immune cells get to a point where they can't withstand the environment, they die too, and become part of that pool. Initially, the debris might be intermixed with healthy tissue, but over time it can coalesce into a single area, a process that's often sped up when more immune cells get involved. Around this pool of pus, a wall of fibrinogen, which is the same protein that holds together blood clots, starts to harden into a barrier. Occasionally, sheets of fibrin form septations, creating loculations or pockets of pus within the abscess itself, kind of like an abscess within an abscess. Even though the pus is largely dead material, there are still plenty of live bacteria within the pus, which makes it highly infectious if it gets spread from one place to another. One of the most common bacteria found in abscesses, especially in the skin or underlying soft tissue, is Staphylococcus aureus. In fact, Staphylococcus aureus releases the enzyme coagulase, which helps speed up the process of building the fibrinogen wall. In contrast to an abscess near the skin, ones that originate deeper in the body often happen in spaces that are already relatively walled off. For example, in the gallbladder, if a stone blocks bile from flowing out, it essentially becomes a new home for bacteria. Bacteria from the nearby small intestine can easily sneak past the stone, crawl into the gallbladder, and multiply, which causes an inflammatory response, and eventually an abscess might form. Typically, these deep infections are a mix of aerobic bacteria that use up all the available oxygen and anaerobic bacteria that can only live in its absence. As far as symptoms go, abscesses typically cause signs of inflammation, which are redness, warmth, swelling, and pain. For abscesses on the skin, they often come to a head over time, where the tissue overlying the abscess breaks down, allowing it to drain out by itself. People with weakened immune systems, like newborns and those undergoing chemotherapy treatment for cancer, are at particularly high risk because they're not able to wall off the infection, which allows the bacteria to get out of the tissue and into the bloodstream. In these situations, symptoms can also include fever and vomiting. Diagnosing an abscess in the skin or soft tissue is usually done by feeling it, or sometimes with an ultrasound of the area. When an abscess is filled with enough fluid, it becomes possible to feel the fluid move around, and this is called fluctuance. A deeper abscess is usually diagnosed through imaging studies, like ultrasound, CT, or MRI scans. Intravenous imaging contrast can really stand out around an abscess, since the small blood vessels around the abscess remain dilated and leaky due to the constant inflammatory response. And this is called ring enhancement, since it lights up the blood vessels around the abscess. Generally speaking, infections are treated with antibiotics alone, but in order for antibiotics to work, they need to first reach the bacteria, and that's usually done through the bloodstream. Since abscesses don't have blood vessels inside them, the antibiotics can only diffuse into the abscess, and that's not very effective, especially when dealing with a large abscess. You can imagine it getting to those guys close to the edges, but there's no way it's getting to the bacteria in the middle. That's why the most important treatment for an abscess is incision and drainage. In other words, cutting it open and squeezing out or somehow removing everything inside. Doing this thoroughly is important so that all the septations get removed, and that no parts of the abscess remains intact. Oftentimes there can be a large empty cavity that remains afterwards, and this can easily get reinfected. To prevent that, large abscesses are drained and often packed with gauze to fill the space, until that tissue heals naturally on its own over time. Deeper abscesses sometimes have to be drained with long needles or surgery, depending on the location. Finally, antibiotics are sometimes used even after the drainage to make sure that there are no additional bacteria lingering around. Alright, with all that in mind, here's what you've all been waiting for: a video of an abscess on the earlobe being drained. Buckle up.
Can you see okay there, Miss Jenny?
Yes.
All right, we're going to make a little stick on this. You ready? And we're getting a whole bunch of pus coming out right now. You see that? How you feeling?
Sorry.
I'm alright.
We got a whole bunch of pus coming out of there. Wow. Here comes more. I can't believe all that was in your ear. I'll get another 4x4 here. How's your pain? You okay?
Yeah, I'm alright.
More coming. Oh, yes, honey. You gotta feel that.
Alright, as a quick recap. Abscesses are a fun mix of immune cells, pathogens like the bacteria Staphylococcus aureus, and dead tissue. Because there's no blood supply to the middle of an abscess to deliver antibiotics, it usually needs to be cut open so that the pus can drain out. What's up, guys? Thanks for watching. Hope you liked it. Huge special thanks goes to John Gilmore, aka the Cyst Buster. He helped both write the script for that one as well as provided that nice video footage, which if you liked it, definitely head over to his channel, The Cyst Buster. It's got plenty more where that came from. Also, thanks to Charles B. Davis for helping to write the script, as well as Rishi for editing the script. As always, you guys can help support us by donating on Patreon or subscribing to our channel and following us on social media. Also, check out our subreddit, r/osmosid. It's pretty new, so it needs some subscribers. All right, guys. See you later.